topic of strategies for screening and reporting. So when we partner with physicians, or if we are wanting to set up a little satellite by ourselves for DR screening, what are the strategies for screening and reporting as for the type of devices we can use and the type of automated reporting which is there, which can help enhance screening and reporting for ourselves and our physician friends. So for that, I call upon Dr. Shelinder Sabarwal and ask him to provide the current recommended guidelines and best practices and feasible solutions for ophthalmologists looking to engage in systematic screening with regards to imaging and AI tools.
Thank you. Yeah, I think if we talk about screening, it's basically we have to make sure that it is not costly, it is affordable at all levels. So right now, what I feel, there are a lot of cameras which are available.
Dr. Shelinder, shall I move your slides for you? I have your slides here if you want.
Okay.
Yeah, just for, yeah.
So they could be handheld cameras, they could be fundus on phone cameras, which are now getting more and more affordable by the day. Then there could be different strategies, whether you want to dilate or not dilate. At least we feel it depends on which level of care you're thinking about. It might be very easy to dilate if you're looking at an ophthalmologist clinic where something can be taken care of. It's being used as a triage for a high volume clinic. May or may not be that sort of safe to dilate always in at a primary health center or a primary vision care vision center. Then there would be these models which are integrated with AI, and obviously AI comes with a cost, but there could be also without AI, like Dr. Kim just said. I think we tried earlier without AI, and because of the lag in reporting, you tend to lose the patient. And it's very difficult, as it is, the compliance is so low, it is very difficult to get back to them. And I think AI is definitely helping there in terms of what we can do at the point of care. Another thing is that what we have also noticed, and I think it's again to do with maybe our not creating the awareness that diabetes can make you blind, despite showing the pictures to the patient, not more than 40 to 50% people are still coming from the vision centers. And I think what we have now started doing, and we are doing it as in a study mode now, is can we upload these images on a teleophthal platform again, because there's a regular teleophthal running and somebody sitting there, and just for counseling sake and not for diagnosis or making sure. So we'll see what the results are, but right now that again is a challenge. These cameras can be handheld if the optometrist can be trained very easily. What we have seen is within a period of few hours they can be trained to use these cameras. Then there was a question about OCT. I don't think even AIOS or Retinal Society recommends right now OCT in a screening model. I think more or less because of the cost which is there. If we go to the, can we go to the next slide then? Yeah. So the type of image again is, I mean, obviously it is ideal to have all those 7 images and a gold standard, but it's not practical. And what generally has been shown in some studies is that even a 45 degree, just capturing disc and macula, one image, non-mydriatic, can be as sensitive as a direct ophthalmoscope, which is not bad in terms of if you're looking at primary health centers or primary eye care centers. I think that can always be there. And at even if you're deploying cameras at a physician clinic, we don't expect them to take multiple images. I think that one image can be good enough. We might have to make our own sort of protocols depending on where we are. I mean, there can be a protocol saying that maybe 20 to 30% of Indian eyes might not be gradable with this small pupils and early cataracts. So what do we do with them? If you feel the compliance is good, we can just refer all of them. Otherwise, the next step could be dilate and take, depending on where you are doing it and how safe you think dilatation is there. I think that is where we feel. So in our setup at the primary care, we are not very sort of comfortable dilating. So right now we're just referring those patients, still struggling with the compliance. If we look at the AI part of it, at least I'm not aware of any specific law, but right now we can be very clear that there are these guidelines from ICMR and Digital Personal Data Protection Act. We have to think about the informed consent. We definitely need a clinical oversight who's going to ultimately the responsibility stays with the physician or the ophthalmologist and not with the machine. and machine and the AI protocols can only basically guide you. You might have to make sure that the whatever we are using is well published and validated, and fortunately we have that now, at least for DR. Good enough sensitivities are there for referable DR at least, and cost has to be taken care of. Even if you see the reports that we get out of AI, they're quite logical in the sense they clearly mention that this is just indicator and not a diagnostic report. And I think that's the way to go, and we have to play safe right now. But like again Dr. Kim said, I think having AI can make a lot of difference in terms of compliance of the patient, and that is what we are seeing at. And the next step we have to look at further, how do we improve compliance. So I think that's the way we are looking at SHOFs at primary and secondary level. As per the integration is concerned, we are right now not into too many physicians clinic. We have tried in primary health centers, some of the cameras and even referrals with mixed results as of now, but we need to scale up. Thank you.
Thank you. Thank you so much.